The Senate is still considering how to deal with the state children's health insurance program, and if you're interested in that, I urge that you contact our senators about supported continued funding for children. This is the second in this format of our ethics conferences. The intent of these conferences, and Ben will echo this also, is to not necessarily provide the answer, but to provide a forum for conversation around difficult and complicated issues. And one of those critical issues is the whole feature of what to do for a child who's from near or far away, who has complex medical needs. We fix them in some level and need to send them back home in our patient-centered view, and where are the issues that come up in that. I'm going to have Ben do a much more formal introduction, but Dr. Wilfond.
Thank you. Welcome to Ethics Grand Rounds. I just want to begin with a few introductory comments. As Tom explained, the format for this will be we'll begin with a case presentation for about 15 minutes or so. After the case presentation, there'll be a chance for people to ask any questions of clarification. And after that, our commentator will spend another 15 minutes commenting about the case. And then that should give us a good 25 minutes or so for discussion with the audience. And for that reason, we do have the two microphones in the aisles as a way of trying to emphasize the importance of that discussion. So if you have a question, come to one of the microphones, and that'll be a way of us being able to recognize you. The other thing I want to mention is that the way we're structuring this is that these are based on real cases, but we've modified them somewhat. So these are really meant as Tom said, as a jumping off point for further conversation. It's not meant to be a retrospective review of the case, and the case is not exactly entirely accurate, but we have enough accuracy so people can actually ask questions about the case if they have specific factual things. So let me begin by briefly introducing our two speakers. Our first speaker will be Patrick Healy, who is an associate professor in surgery and the chief of pediatric transplant surgery here at Children's Hospital. He received his MD from Boston University and did his surgical residency in Connecticut, and then came to Seattle in 1993 to begin his fellowship. He first did his fellowship in Pittsburgh, and then he came to Seattle for further training here. Our second speaker will be Christine Grady, who originally trained in nursing and then got her PhD in philosophy, and is currently at the NIH Department of Clinical Bioethics, where I had the privilege of working with Christine in the past. And she has a particular interest in ethical issues related to international research, and that's why we've invited her today. So let me turn it over to Patrick.
Well, thank you, Ben. So I'd like to present this case that is a good example and raises several questions of providing complex medical care in a different setting, particularly in another country. The child is a 26-week gestational age boy who was born at 938 grams. Mom is a 30-year-old woman, and this is her first child. She's a native of the Bahamas and is by profession a nurse. She was an active clinical nurse in practice there. Her pregnancy was complicated by a prolonged rupture of membranes. She actually had a cerclage during early in pregnancy. She had an infection, chorioamnionitis. Birth was by C-section, and the APGARs are listed there, 5, 6, and 7 at 10 minutes. This child's history is that he was intubated and ventilated initially for 2 days, received surfactant, and was uneventfully extubated. Over the course of the next few days, it became clear he had sepsis and meningitis. He was treated with antibiotics for 3 weeks with good clinical response. They diagnosed by ultrasound a bilateral grade 1 intraventricular hemorrhage. Now, he continued to grow, and feedings were initiated somewhere in the second week of life, where he then around day of life 19, he developed necrotizing enterocolitis, termed medical here, in that he had the abdominal symptoms, sepsis-like symptoms, had an X-ray which showed pneumatosis, which is air in the intestinal wall, and responded well to antibiotics. Toward the end of that course, he had as he was recovering, he had his feedings advanced again, and yet on day of life 35, he redeveloped abdominal distension. He became quite acidotic and had pneumatosis. At that point, he was reinitiated on antibiotics, and his feedings were stopped. And then 3 or 4 days later, he was transferred over to Children's. This is an X-ray which it might be kind of hard to see, but it's a very worrisome X-ray for necrotizing enterocolitis. As you can see, this is a small child. There's a lot of gas throughout the abdomen, throughout the bowel wall. I don't know if you can see it quite well. There's almost a double track sign right here, where you can actually see a column of air throughout the lining of the intestinal wall. And particularly worrisome, in this is the liver up here. You can actually make out a brief sort of Y-shaped air pattern here. That's actually air within the portal vein, which is a very strong indicator for intestinal necrosis. So as I met this mother and examined the child, evaluated his condition, she had these at the bottom. Actually, these are I put some quotes from Mom along the course of taking care of this child that I thought would add a little bit of perspective on where we were in the discussion along the way. Now, Mom, being a nurse, had watched this child get sick once, get better. Then she saw him getting sick now for 3 or 4 days in another hospital. And this is one of the first things she said to me. I knew he wasn't right. A little newborn baby shouldn't look like that. I should have said more. And is he going to die? Is he going to be able to make it through his surgery and survive? When will we know? I said, well, she hit the nail right on the head with just about every single one of those issues. To me, she was very aware of his clinical situation. She had enough clinical experience. She was rightly upset. I think she was a little bit feeling responsible, maybe, that he got as sick as he did, but felt uncomfortable. And I think that being from another country in an ER or in an ICU here, she felt a little out of her place to say anything. So we, on that first day we examined the child, we operated on him, and he had an exploratory laparotomy. And at the time, he was found to have necrotizing enterocolitis throughout his entire intestine. His colon was spared, but the entire small bowel. There really wasn't one area that was worse than another. None of it was normal, yet none of it had fully perforated. So there wasn't any clear area that could be removed, leaving healthier bowel behind. We also developed some bleeding from his liver during the case, and at that time we did a ileostomy, which, in an attempt to drain some of the contents of the bowel, and packed his abdomen because of his bleeding. He actually clinically stabilized over the next 2 to 3 days, but quite ill. Was intubated on high support, required inotropic support. And 4 days later, we went back to surgery for what's called a second look laparotomy. And at this point, if areas of the bowel had recovered, they could be salvaged. If areas of the bowel were showing progressive disease, they could be removed. And after resection, he was left with 37 centimeters of small bowel to an end stoma, plus his entire colon. And at the time, just as a point of reference, his bilirubin was 2.5. Now at 43 days of life, a bilirubin shouldn't be 2.5 in general. So at this point, after surgery, mother asked me, well, will his bowel recover? Can he still tolerate all of this? And will he survive? Her focus on survival was obvious and very present in the conversations. And if he's not able to survive, should we withdraw support? So she was wondering right from the get-go. I didn't actually have to introduce this idea, although it is one of the ideas that, or one of the issues that is encountered with all of these children with critical illness. So this is now day of life 75. 1 month later, he's been weaned and extubated. He's on room air. He's had no neurologic consequence of either his intraventricular hemorrhage, his sepsis, his necrotizing enterocolitis. His bowel function has not recovered, however, and he's remained on TPN. At this point, 1 month later, his bilirubin is almost 7 at this point. And because of the delay in bowel function and stoma output, we reoperated on him, and he was diagnosed with, he was found to have strictures in his intestine, areas that we preserved did not recover normally. So with the strictures, he had several resections and anastomoses, and we closed his ileostomy to make his entire GI tract in continuity. And at that point, he's left with 15 centimeters of small bowel plus his entire colon. And again, Mom, at this point, wants to know, well, can he survive with this amount of bowel? What kind of life will he have? And right up front, she said, I'm not interested in a transplant, in an intestinal or a liver transplant. We could never do that in the Bahamas. What and when can we take him home? At this point, so now this is 2.5 months, and she's in a full month after his initial illness. She can see that this is going to be a protracted course. So about 15 days later, his bilirubin had gotten up to 8. We started feedings. His bowel function had recovered, and by 1 month after that, he was tolerating roughly 20% of his feeds enterally. Bilirubin had started to come down, which we would expect, which is one of the things that we look for with enteral feedings. Her questions at this point: how long will he need TPN? Now, can we transfer him to Miami? Because that's actually there's an intestinal center in Miami close to where they live. We looked into it, and she said that TPN is not an option for babies in the Bahamas, and she has to return home to work. Would it ever be possible to stop his TPN and just withdraw his support? Now, at this point, we had the first of our 2, I think, ethics, or maybe this was the second, ethics consults in the hospital. The ethics committee here reviewed the case, discussed the case, and actually, the answer to withdrawing support was, at this point, that it wasn't really clear what his outcome would be, so that it would not be, it was felt that it would not be in the best interest of this child at this time to withdraw his support. And he certainly wasn't ready to tolerate 100% enteral feedings. If you flash forward 1 more month, he's now up to 40% of enteral feedings, and bilirubin is now down to 4. At that time, he remained hospitalized. He has since been discharged, and parents have had to return to the Bahamas and have come back and forth to visit every 6 to 8 weeks. Family is, the child is in the care of cousins or mother's cousins in the Snohomish County area. And at this point, one of the visits back, mother says, "This is no life for this child. I want to take him home." So some questions that come. I think there's probably more, Ben, than actually just 2 or 3. But he wanted to focus, so I think that was a good idea. First question, should the mother be permitted to take this child home to the Bahamas? In looking at the support services available, there really weren't sufficient TPN, radiology, and surgery services to provide maximum care, optimal care, and maximize the survival chances associated with long-term TPN. They do have TPN available in the hospital. It's regulated, its availability is regulated, and it's generally considered to be for short-term use only. It's very resource intensive. The complicated babies, they actually transfer to Miami or to another hospital in the States. They don't have facility to do outpatient TPN. So the family actually, that's one of the issues that factored into their decision to stay in the Seattle area where they had family. They had outpatient services. They also were more familiar and comfortable with the providers here than in the new area in Miami. How important is the expected clinical outcome in the decision as to whether a mother can take this child home? Should the response be different, or would the response be different if the child lived in Seattle or Alaska? And lastly, how do you balance the family and the child's interests? That would be my transition slide. Are there any questions about the clinical case? I'm sorry. Well, thank you.
Can you hear me? You guys hear me? Well, I'm honored to be invited to talk to you today about this very interesting and difficult case, and I'm glad Dr. Pendergast said that the goal is not to give you an answer, because I'm not going to do that. So don't be disappointed. And the first thing you'll see that I did is slightly change the title. Ben had sent me a title that said, Discharging an Infant when local medical care is not adequate, should there be a double standard in the developing world? And I'm going to get to the second half of that, but I'd like to operate first on the first half of this title and change it slightly to might not be adequate. I work for the federal government, so everything I say doesn't represent the federal government, and I'm also required to tell you that. So whatever I say is my mistakes. And I also thought that I love this cartoon about, if you think I'm going to tell you how to know the difference between right and wrong, you may feel like this guy in the third panel who says, I already know that, I'm 49 years old. If I choose to make unethical decisions, it's because I want to make them, not because I don't know the difference. So you can leave now if that's the way you feel. So I'm going to start with the first question that Ben put on the slide. Should the baby's mother be permitted to take the child home to the Bahamas? And I want to suggest, which Dr. Healy already nicely suggested, that there are many relevant considerations in trying to answer this question. First, of course, what are the baby's medical needs? And you heard about the necrotizing enterocolitis and short gut syndrome, and I wondered actually out loud as I was preparing this whether a preemie of this birth weight might have other medical needs as well, but I haven't heard about any. So, as I understand the treatment options, long-term TPN seems to be the most important thing to keep this baby alive. It's not, as I understand it, an option that he might be able to have for life, even if he stays right here in Seattle. Another option is experimental bowel transplant, which is experimental and also something the mom said, at least at this point, she's not interested in. I think critical is the question, what's the prognosis? And you heard already that at best, I guess it's uncertain. As I understand the course that this child has taken, he's sort of gotten a little bit better a little bit at a time, maybe in an unpredictable way. That could change, as I understand it, at any time. He could stop getting better. He could not tolerate TPN. His liver functions could get bad. There are a lot of things that might happen to him. Even if he stays here with optimal, maximal medical care, his prognosis is uncertain. And then I think a very important question, of course, is what's the best interests? What are in the best interests of this baby? And I'm going to get back to that in a second. And then critical, of course, is this understanding that treatment options and therefore prognosis critically depend on where the child is cared for. Because as you heard, TPN is available to him here, but not reliably anyway in the Bahamas. But also the resources and the expertise to handle the complications and maximize this baby's survival are available here, but not, again, reliably in the Bahamas. So I want to go back and just for a minute talk about how we think about hospital discharge in general. And of course the goal is to find a place where people can recover well after they leave a hospital and reduce the risk of rehospitalization. And there are Medicare regulations, which you probably know better than I do, which require evaluation of the patient needs, the availability of the services, that require informing the patient or the authorized representative, respecting their preferences when possible, and then implementing a plan for safe and adequate care. Usually, as you know, this works. People get discharged from the hospital all the time. And it usually works without a lot of problems because there's an alignment between what the patient wants and what the hospital wants. They want to get the patient home to a place that, or out of the hospital to a place that promotes his or her best interests. And in most hospital discharges, the preferences and goals of the patient, especially a competent patient, are absolutely critical. But there are lots of examples where this doesn't work, where the interests aren't aligned. And I have too many on this slide to talk about, but let me just highlight a couple of them in the interest of time. Certainly we know there are cases where the preferences of the patient are not compatible with his or her best medical interests. And in a competent adult, we honor that. We have examples of cases of patients who refuse to leave or are very difficult to discharge from a hospital. And then those who leave against medical advice, and on and on. We had an interesting case recently where I work of a patient who desperately wanted to leave, actually walked himself to the door, and the psychiatrist actually decided that he was not competent to leave because he was delusional. We also have cases where this thing that's been all over the paper about the patient or the person with tuberculosis traveling around the world, where there are circumstances about individuals who are in the hospital that make it unsafe to discharge them for other potential harm to others. We also know that what safe and adequate care, if we're discharging people to safe and adequate care, what that actually means, it falls on a continuum. I mean, certainly it's somewhere between no care at all and the best possible imaginable care that a person can get. But what's adequate and safe along this continuum requires a lot of judgment and a lot of context in every case. So I don't want to forget that in terms of how we're thinking about it. And again, examples, I have plenty of examples. I think I'll just point to two of them in this list. The first is a person that we dealt with at the NIH who had cancer, lived in a trailer in rural West Virginia with no running water, no telephone, a neighbor that was a few minutes down the road, a son that was about a half an hour away. And this gentleman wanted to go home when he finished his chemotherapy, and the question was, is that a safe place to discharge him to, given the kinds of needs that he probably would have? It was a very tough case to resolve. I want to point you to the last one on this list. This was a child who had had a bone marrow transplant for aplastic anemia and actually successfully transplanted with respect to her underlying disease. But she had fairly typical complications of bone marrow transplant. She had chronic graft versus host disease, and she had some other issues that needed to be attended to. And she and her mother wanted to return home, which for them was Guatemala. And the question of, is the care that she will receive, and especially the expertise to handle the complications of post-bone marrow transplantation, available in Guatemala to the extent that it will be safe to transfer her there. So then the question does arise, of course, who decides what's adequate? And in most cases, for adults, it's the adult, the competent adult. And then we have these two standards, substituted judgment and best interest. Substituted judgment is usually used for incompetent adults under the assumption that at some point they made their wishes known, and therefore the surrogate will act in accordance with what they think the adult would have wanted had they been able to make their own decision. That, of course, is not possible in the case of an infant who has never had a life to be able to express any interests, and so decisions are all made on best interest standard. And in every case, no matter how the decisions are made, it depends on full and accurate information constantly being given to the decision maker. And so when one discharges a child or an infant, again, the team recommends a safe, adequate, affordable care, compatible with the child's interests and rights, and usually agreed to or decided upon by the parent. So, what are kids' interests? I mean, they're huge. I put a bunch of interests on this slide. You can read them. You can agree with them or not agree with them. I'm sure there are many that I didn't put on this slide. But my point here is just that when we are considering best interests of a child, that it makes sense to consider more than just survival. Although survival is absolutely critical, there are many more interests that a child, a person, but including an infant, has. There are also rights that many contend that children have. And the UN Convention on the Rights of Children is often employed to talk about certain rights that children have: the right to life, the right to protection from harm, the right to separation from their parents, protection from separation from their parents, the right to a standard of health care that's adequate, and a standard of living that's adequate. And we all know that these things don't always happen, but there is some level of agreement that children have a right to these things if we can provide them. Except in the United States, including in the United States. Well, we don't sign on to the treaty, right? So, all right. So, who can speak for the child's best interests? Usually the parents. The parents are usually in the best position. You guys work with kids all the time. You know this better than I do. They're in the best position because they know the child and almost always have the child's best interests at heart. And the law assumes that the parent will act in the child's best interests. And there are, of course, reasons why the parent might be conflicted about how to decide in the child's best interests. But most of the time, we assume that parents act in the child's best interest and only interfere when the decisions are incompatible, clearly incompatible with the best interests, and have potentially serious consequences for the child. Loretta Koppelman wrote a paper that just came out a month or two ago in the Journal of Law, Medicine, and Ethics on applying the best standard, the best interest standard, And she said that it should require these three things: that decision makers should use best available information to assess the interests and choose, as a prima facie choice, that option that maximizes overall and long-term benefits and minimizes burdens for the patient. That choices must need a minimal threshold of acceptable care that's good enough as judged by reasonable people, and that decisions should be consistent with moral and legal duties. I think that the quotations that we heard Dr. Healy describe from this mother suggest that she is considering the best interests of this child. She's asking questions like, will his bowel recover? Can he tolerate all of this? Will he survive? So she's considering, in those three simple questions, she is considering his prognosis, his long-term prognosis, his amount of suffering that he's undergoing, and his potential for survival. She also asks, what kind of life will he have? A reference to, will it be a life that's worth living, so to speak? And, of course, then says, in her estimate, the day that she said this is no life for this child. And she wants to take him home. So one of the questions Ben asked is, how important is the expected clinical outcome to this decision? And I don't think anyone would disagree that it's absolutely essential to this decision, the clinical outcome. If you had a situation where survival was basically not expected, and the parent wanted to do something that you thought was not the best choice at this point in time, but you knew that this child is not going to survive anyway, your threshold for allowing the parent to make that choice is going to be much lower. In contrast, if you have a medical intervention which you know has a reasonable or actually a very good chance of maybe not even curing the child, but good treatment options, a blood transfusion, a temporary dialysis, antibiotics, something like that in the setting of possible recovery of a child, you're going to be much more stringent about making sure that those kinds of options are accepted by the parents and agreed to by the parents. Certainly, in thinking about the clinical outcome, I think it is controversial but reasonable to include considerations of burden and suffering on the child and predictable quality of life. Now, the question is always asked, and this was one of the questions that Ben also put on the slides, how should the family's and the child's interests be balanced? Certainly parents have interests and they have rights, and their parents' interests are not always aligned with the child's interests. Most people agree that in making decisions about infants and children, the interests of the child should trump. Now, that doesn't mean that parents' interests and parents' rights are irrelevant, of course. It just means that they take a secondary role to making decisions about how a baby ought to be treated. There is also, of course, interests of the family in a larger way, not just the parents themselves. In this case, I understand there aren't any other children, but there could have been siblings. There could have been other family members that would have been impacted or are being impacted by the decisions that the decisions that are being made about this child. So, for example, I understand there's cousins and aunts and uncles, perhaps, that are caring for this child here. They have interests, too, in this discussion. Again, they don't, the interests of the baby, the best interests of the baby trump, but the interests of these family members are not irrelevant. And many people talk about, in the literature anyway, family-oriented care, which tries to take into account both the interest of the family and the best outcomes for the child in some way. So what about overruling parents? Let's imagine this mom didn't say, when can I take this child home, but I refuse to agree to any further therapy and I want this child to go home today. The question then becomes, does that reach the level of negative decision-making on negative consequences for the child that you as a team or the state might interfere with with her wishes? Certainly there are plenty of examples where the state does interfere with the parents' wishes or decisions in the interests of the child. One that you probably know a lot about, that I just read about in the newspaper, was baby Riley, who was here in Seattle about a year ago. A mom who essentially kidnapped her child out of the hospital because she didn't want him to be put on dialysis. And she was put in jail for kidnapping, and the child was taken away from her and given the treatment that he needed. There's been a lot of discussion about treating HIV-infected kids whose parents don't believe that HIV is caused by HIV and responsive to medications. A famous case in California, Christine Maggiore, who's been in the news a lot, and her 3-year-old daughter, Eliza Jane, died from the complications of HIV disease but had never been tested or diagnosed, and there was an investigation into whether or not this was child abuse or neglect. There was an interesting case in Texas that went to the Texas Supreme Court, Miller versus the Hospital Corporation of America, where according to the recommendations of many people, these parents were suggested to write an advance directive about their preterm infant before the baby was born. The baby was born at 22 weeks, and the parents signed a directive that said they did not want the baby to be resuscitated. And that's been in the literature. People are talking about this as an option. The hospital resuscitated the baby anyway, and the parents sued the hospital for battery, and the hospital won the case in the state of Texas. So what does this mother want, and why does she want it? I think we have lots of very thought-provoking quotes from the mother, and we can make some assumptions, which may or may not be true, but I'm going to make them anyway. She wants to go home, where she has a family and a job and a life, and she wants to bring her baby with her. She seems to understand that TPN and other needed medical care may be hard to arrange at home, but I think there's still this interesting question about hard to arrange, but perhaps not impossible, especially as the baby's needs seem to continue to change. She is concerned, or she expresses concern that reflects she's concerned about the baby's overall best interests. What kind of life will he have? So I think an interesting question to ask is sending the baby home equivalent to what people call selective non-treatment? Or is the decision more about withdrawing care or selective non-treatment, or is it really about determining the adequacy of care? And I think those are actually different questions. Now, they may end up looking awfully close and hard to separate, but I think that the withdrawing of care is a decision based on many of the same considerations, but it's a point in time where the decision is made and then you take the consequences. Whereas determining the adequacy of care takes into account changing needs of the baby and changing circumstances that might be, changing options that might be available. This same article that I mentioned a little bit ago that Loretta Koppelman wrote said she contends in this article that the current tough cases in neonatal intensive care units are cases where clinicians struggle with the different guidance given by the CAPTA baby dough rules. And you probably all know this, but it's Child Abuse Prevention Treatment Act baby dough rules, which are very restrictive in terms of when treatment can be withheld from a premature newborn, and the best interest standards. And she suggests that we are being discriminatory to infants by requiring this very strict set of rules that are strictly laid out in CAPTA instead of a best interest standard, when we allow best interest considerations for every other person who's over 1 year of age that we make decisions about. And she argues that best interest standard should be the proper guidance for decision makers for patients of all ages, including infants. Now I want to get to probably why Ben thought I could talk about this case now that I've come to the end. The question about whether the response should be different if the baby lived in Seattle or Alaska instead of the Bahamas, and should there be a double standard for the developing world. And I guess I would start by saying emphatically no. There should be no double standard. And the response should be the same, regardless of where the baby lives. And what I'm going to say about that is two things. One is maybe it's the words, or maybe it's the idea of what double standard means. I mean, basically, double standard means that you apply a standard more leniently to one group to another. That's a pretty simplistic definition, but that's usually what it means. And it's usually a negative. It's usually, we don't treat the groups equally. We don't care as much about the second group, or there's some negative connotation to double standard. We don't hold them in this high esteem, and therefore we treat them less well or treat them more leniently. All of you are familiar with, we've been talking since I was a kid about double standards for teenagers. Teenage boys are allowed to be rowdy and have sexual interaction. Teenage girls shouldn't. That's changed a little since I was a kid, but not that much. It's still out there. I think in the world that I live in, which is the world of clinical research, at the ethics of clinical research, double standard is an accusation that comes up all the time, that we allow research in the developing world that we wouldn't allow in the United States or another developed country. Again, in that I think that accusation is empty without the details of what a particular case are. I don't think that there's a general rule or goal to treat a developing country, more leniently or more exploitatively than there is to do research that might be helpful to them. So that's a completely different issue, but it's where double standard comes up a lot. So I think in this case, when you're thinking about discharging an infant, I would argue that there should be no double standard, that the standard that should be applied across all cases is the one that you probably already do apply, and that is that parents, armed with as much information as possible about the options, the prognosis, the clinical needs and outcomes, make decisions about their child's medical care compatible with the child's best interest. That would be the standard. And that in exceptional cases, therefore, the decision-making may have to be taken away from the parents because it's judged that they are not acting in the child's best interest. But the standard, the parents make the decisions compatible with the baby's best interests, I think is the standard that should not be applied doubly or more leniently in one case than the other. It's the standard that should be applied across the board. Let me skip that. So I'm going to end with, should the baby go home? And I will admit, I don't know as much about the clinical details. I learned even more from Dr. Healy's description than I did from his slides, which I saw over the last few days. But I think that when the baby's clinical status is such that he can be safely transferred and plans are made for care that, given his best interests, are adequate and reasonable, as judged by reasonable persons. Now, that may sound like waffling, but I don't think it is, because I think you've already seen this child has gone from, I forget the numbers, 10% bowel function to 40% bowel function. You know, he might go up to 60 or 80% bowel function at some point, at which point you might reconsider whether or not, or 90%, who knows, you might reconsider whether treating him in the Bahamas with the possibility of maybe intermittent TPN is an option. I don't know if that is or ever will be. It's also possible, as I understand it, that his clinical course could take a turn for the worse, and that his bowel function would not improve anymore, and that he would begin to develop liver failure. And at that point, I think this gets revisited. Is the care that can be given to him in his best interests, in his home with his parents in the Bahamas, adequate by reasonable person standards to allow him to go home? And so I would suggest that the decision for this baby, I think the decisions that have been made thus far seem fine, but I don't think it's an end. There are no final decisions here. This is an issue that will continue to, and should continue to be revisited by the parents and the clinical team here. That's all I was going to say.
Thank you, Christine. So we'll now open up for questions. If you'd like to come to the microphone.
It will be funded by Medicare for the last 8 years. It is the standard of care for patients with end-stage intestinal failure with life-threatening complications. And so one has to also consider in these circumstances whether not offering the standard of care for a patient who may ultimately need transplantation is also a consideration. But I think it's very important that people understand that this is not experimental treatment.
Okay. May I ask you a question? Or maybe Dr. Healy wants to say something first, and then I want to ask you a question before you.
I can speak to that initially. Simon brings up a very important and accurate point that intestinal transplant is not experimental. We have a program here that's active, and we're all being introduced into the clinical arena of intestinal transplant as well. that isn't your question about whether intestinal transplant should be offered or the opportunity for transplant be offered is definitely a very big ethical question that, for the purpose of this discussion, we didn't go there. But nonetheless, there are, in the context of this particular patient, there, in deciding who would be appropriate for transplant, the issues of being able to be taken care of before and after and maintaining a transplant all go along with successful transplantation. And some of the issues about, actually I thought it was interesting, the patient that you mentioned from Guatemala trying to be cared for after a bone marrow transplant. There are similarities to a post-transplant intestinal patient who might have to return to the Bahamas as well. I fully agree, Simon, that intestinal transplant is not looked at as a experimental offering, but it still is one where, at least to date, families have the option to opt out of pursuing that, or maybe they have been allowed out of it by centers. I'm not aware of any where intestinal transplant has been offered and carried out against the parents' wishes. I think but that raises a whole other category of ethical issues that we just didn't include on the topic today.
At the risk of being pilloried, I want to bring up a couple of other issues. First of all, why was treatment not withdrawn in the Bahamas, where conditions were not conducive to survival of this child? Secondly, if I remember correctly, there's some old epidemiologic literature that shows that when middle-class parents have poor birth outcomes, there's a high perinatal mortality for the infants. This mother was a nurse. She's a middle-class a parent who should not have such a tiny premature. And the expectation for long-term survival is probably limited. Now, this sort of epidemiology should be revisited because of all the changes in perinatal care recently. And the other issue is, why do we accept kids like this from third world countries to invest huge amounts of effort and money with the possibility of not long-term survival with any decent quality of life for the child or for the parents, when we have American children, and perhaps even in this area, who die from garden variety illnesses which can be easily treated, and we take kids from other countries. We don't have the responsibility for other countries. We have responsibilities for American children primarily, and we still are not fulfilling those responsibilities.
Yeah. Thank you for your question. I perhaps wasn't very clear. This child is the child of Bahamian parents. The mother was actually in Washington State when the child was born, so the child is actually an American citizen and born in Washington State. One of the things that's clinically taking care of this child that was interesting, and we may have been slower to grasp, mother's questions about survival and about how much support. She may have been asking from the perspective of this child surviving at home in the Bahamas, and we may have been mostly interpreting and communicating all survival in our hospital, survival in our community, because that's our standard of reference. I think that after it became more clear that this was going to be a chronic or a more longer-term issue, that's really where the difference has been clearer. And I think that actually one of the features about adequacy of care really is what this is all about. Had this child been born in the Bahamas, the child wouldn't have survived the neonatal period. That's very true. Yeah.
Christine, do you want to
I want to pick up on one thing you said. I don't know the data that you were referring to, the epidemiological data. Why did this woman deliver a baby at such an early stage? We didn't hear anything about that. I don't know if there was anything about her prenatal course that might suggest, I don't know, that she didn't take care of herself in an adequate way. In other words, information about her that might suggest that her interests were not centered on the child. I'm not saying they were. I'm just saying that that's a question that I think is relevant to consider.
She did have history of premature rupture of membranes and chronic intrauterine infection, chorioamnionitis, and actually had a procedure early in pregnancy, 15 or 16 weeks of cerclage to try to sustain this pregnancy. So I think that there were prenatal issues that contributed to the poor growth of this baby.
Also, I'd like to just put back on the table your question about, we have many American children who need care, and why should we be taking care of children from the developing world? Now, this baby happens to be an American citizen and a citizen of Washington State, so it's a moot point in a certain way. But I think it's a really interesting challenge. If you have a child, let's say wasn't born here, but came here at age 3 months or something, and then developed a terrible illness, and for which discharge to adequate care at home was going to be very hard. What should we do with a child like that? We can't, I don't think we can, with good conscience, just say, throw them out the door. We have to still consider what are the best interests of this child and still try to arrange adequate discharge plans for a child to be taken care of somewhere.
I want to thank you both for a wonderful presentation of the case and the questions of the case and a wonderful discussion of it. I think it's wonderful that Children's gets a chance to revisit these ethical questions on a regular basis because they're so critical. Couple of thoughts. From the family standpoint, I think one study showed that a seriously chronically ill child leads to roughly a 90% divorce rate in families. There's huge stressors on families. So the best interest of the family in relation to all of these very sick children, I think, is critical. Also, it's a bankrupting situation. Bankruptcies in the United States are most commonly sought because of excessive medical expenses. Also, in terms of international relations, there's already a built-in double standard given the quality of Western medicine, of developed medicine, and what's available in most of the third and fourth world. And it raises the question at an international level about distribution of resources, distribution of wealth worldwide. The clinicians with an individual baby are stuck with I think, an almost impossible decision about how much care to provide when highly expensive, highly intensive care is available, but then essentially means that somebody else, maybe hundreds or even thousands of others who could benefit from that same expenditure, aren't getting care. Just any comments, if you wish.
I think, one of the things that I actually stayed away from, and you might have noticed, is cost. I try not to talk about it because I mentioned it only once. Because it complicates everything. It complicates everything in terms of how we ought to think about what to do for an individual in any case. I think it always does.
But it's very real for the families.
It's very real for families with disabled children. It's very real for families who come to the United States looking for some kind of care that they can't get in their own home country. And those are, I agree with you, those are thorny problems that we haven't worked out yet. I also think the issue of double standard, I mean, I railed against the use of that terminology. I agree with you that the level of resources and level of care available to people is very different from one country to another, and that there are places in the world, many places in the world, where the level of resources available are unconscionable. That people can't get good prenatal care to start with, and certainly in many cases a child like this, with this kind of disability, would never have made it past birth. I don't think, though, that gives us license to say, okay, since the care that he or she would get in that country is so bad to begin with, we can just send them back there without worrying about it. Because I think that is the double standard that I think we should avoid. We have to take into account that circumstances are different and do the best we can to support this child, taking into account, and others like him, all of his interests, and I think, hopefully, at some level, the family interests and the parents' interests.
Some of the good news from this part of the world is that with the inspiration of the Gates Foundation, the global health initiatives are beginning to attempt at least to redress some of these issues.
Absolutely.
Dr. Grady, I wanted to get you to maybe expand a little bit on your last slide, and it actually relates in part to this point and this notion of a double standard, because it seems to me trying to judge best interests on the basis of a reasonable judgment of reasonable people, rather than giving an answer, raises a whole new set of questions, which is, well, who gets to be the reasonable person? And a decision that people would consider to be reasonable here would be considered obscene in Botswana. And it's precisely because they have a different set of resources. I mean, putting a child on a ventilator there consumes their entire gross national product. And so the answer, a reasonable decision by reasonable people, seems too easy because it doesn't tell us, well, who gets to be the reasonable person.
Okay. Well, I told you I wasn't going to give you answers, so I'm excused. No. I hope I made the case. What I believe is that the principal weight in terms of this decision should be on the parents, and that they are the ones that have to decide what's reasonable. There is a threshold, though. There's a threshold above which or below which, whatever direction you go, where you say that parent's decision is not reasonable by some other standard. Now, that's where you get tricky, because if this mom was in the Bahamas and said, I don't want any further treatment, that would probably be a reasonable choice and an accepted choice, because there wouldn't be any other treatment available to her. But she's not, or she might not be, but the baby is not. The baby's here. The baby's an American citizen. The baby's already on treatment. So now we're talking about a different issue, and that is withdrawing treatment. And I think it is, it sounds like there may be a time when it is appropriate to withdraw treatment from this child, and that will be reasonable by the people in this room that are working with the mom to make that decision. But at this point in time, or at the point in time when she first raised it, it sounded like they weren't ready to make that decision as a reasonable choice. Now, one of the things that I thought about when I was preparing this was what if the mom had said, or maybe she did, what if she said, I don't care, I want treatment withdrawn now. Or, I don't care, I'm taking my baby home tomorrow. Now, assuming he was stable enough to travel, let's say. What would the team here have done? I think the choices are, let her go, make the best connections you can make in the Bahamas, and let her go. The other choice is to take the child away from her, call protective services. And that's a terrible choice to have to make. In so many respects, it was fortunate, it seems like, and I only know about the case, I only know what I've read on the slides about the case, but it seems fortunate that she was at least willing to think about other alternatives, think about leaving the baby here and letting her cousins take care of him while he continued to receive this treatment, and not forcing the issue. But I think if the issue had been forced, that decision would have had to have been made. And the question then is, so you're challenging me on who's a reasonable person. The question at that point where she says, I'm taking this child no matter what you do, the reasonableness then falls into the lap of the people who are in charge of the baby here. Is that a reasonable option for her? Can she do that? Should she be able to do that? Or should we stop her and take the child away? With all the consequences, somebody talked about divorce and, cost. If you take the child away from the mother, you are impacting that child's life, perhaps permanently. But
We have 57 seconds left.
Oh.
Quick question.
I'm a nephrologist, and so we visit the ethics committee quite often. And many times we'll have babies that have renal disease severe enough to go on dialysis or need dialysis shortly after life, and we know that it's end stage and it's not going to be recoverable. We do let the family be the reasonable person and try to give them all the information that we can, and then let them, with our help, make the decision whether they want to proceed with dialysis and transplant or actually not go that route at all. But once they've decided to go the route that they want dialysis, then it's in a different realm, because we actually are very uncomfortable with them trying to withdraw dialysis after we've started that sort of treatment. And in a case like baby Riley, that family chose at the beginning they wanted everything done, and rather than to not do anything. So there were interventions already going on, but not dialysis. So then when he comes back to us at an age where he needs dialysis, and they are still saying they want things done, but they want it done their way, that's when we actually intervene and go the route of the CPS and taking the baby.
So can I ask you a question? So it sounds like you feel like there's a different standard for the decision about initiating a treatment than there is about withdrawing a treatment. Is that a fair way to rephrase what you just said? And can you say why there is, or what the difference is?
Again, it's thinking about, the road of dialysis and transplant when you start out as a neonate. It's a really, really terrible. It can be very, very terrible. And so we sort of weigh all those things in the beginning. But then as the child, if they survive or they keep going, or we get mixed messages from the family, it's one thing to remove things that we've already started. And I don't know if I can voice it correctly. We work with the ethics committee, and these cases actually go back to the ethics committee. And again, withdrawing something that's where the baby's doing well on a therapy and on a road that could be a very good life long term, and they've made it through outside of that neonatal period, we are very uncomfortable about withdrawing.
Okay. Well, I think you just said a very important thing in that last phrase, and that is, once you've started on and the baby is doing well and past a critical juncture of, uncertainty, then that does seem different to me, certainly.
Okay. I think we have to end now.
Sorry.
It's okay. Thank you all very much. And thank you to the speakers.
Thank you.